If your legs ache or cramp after a short walk, you've probably done the sensible thing. You sat down, you rested, you waited for the ache to pass, and you told yourself to take it easier next time. That instinct feels responsible. It feels careful, even wise. It feels like listening to your body. For one specific, common cause of leg pain in people over 60, it's almost exactly backwards. For plenty of you watching, the actual treatment isn't rest. It's walking through the discomfort, on purpose, in a very specific way. Sitting down at the first twinge might be the one habit quietly making your legs worse year after year. I know that sounds strange coming from a doctor. Usually, pain means stop, full stop, no exceptions. Today I'm going to explain the one condition where that rule doesn't apply. I'll cover why it doesn't apply, and the exact exercise protocol that outperforms plenty of expensive interventions for it. I'm Dr. Walter Hale, nearly 4 decades of practicing medicine, and this particular condition is one of the most underdiagnosed things I see in patients over 60. Most people carry it for years, quietly, assuming it's just what getting older feels like. Before I explain the science, I want to tell you about a patient, because her story is exactly why I take this condition seriously. What I'm about to describe isn't any single patient. It's a composite, stitched together from a pattern I've watched play out again and again over the years. I don't publish anyone's real medical story without their permission, so think of this as a blend of many cases, not one person's file. For the sake of telling it clearly, let's give her a name. Let's call her Carol. Carol was 66. She'd spent 31 years as a mail carrier, walking most of every workday, rain or shine. Retirement had slowed her down, and she assumed that was simply age catching up with her old knees. About a year into retirement, she noticed something specific. Walking to her mailbox and back, a distance she used to cover without thinking, started producing a deep ache in her calves. She'd stop. The ache would fade within a minute or two, and she'd continue on, a little slower. She mentioned it to me almost as an afterthought during an unrelated visit. "Just old lady legs," she said, laughing it off. I asked her a few more questions than she expected. The pain was always in the same spot. It always showed up after roughly the same distance. And it always resolved with rest, every single time, like clockwork. That specific pattern is not just old lady legs, it has a name, and it's a warning sign worth taking seriously. Here's what was happening inside Carol's legs, and possibly inside yours. The condition is called Peripheral Artery Disease, often shortened to P.A.D. It's the same basic process as the plaque buildup that causes heart attacks. This time, it's happening in the arteries that carry blood down into your legs and feet, not the ones feeding your heart. Over years, fatty plaque narrows those arteries. Blood can still get through while you're resting quietly. Your leg muscles aren't demanding much oxygen at that point, so a narrowed artery can usually keep up. The moment you start walking, your leg muscles suddenly need far more oxygen-rich blood than they do at rest. A narrowed artery can't deliver enough. The muscle tissue starts working anaerobically, without adequate oxygen. That mismatch produces the specific cramping ache people describe. It shows up almost always in the calf, sometimes in the thigh or hip instead. Stop walking, and the demand drops back down. The narrowed artery can catch up again. The pain fades within a couple of minutes. That start-stop pattern has an actual clinical name. Doctors call it intermittent claudication, and it's the textbook symptom of peripheral artery disease. This condition affects more than 6.5 million Americans over the age of 40. The number climbs sharply with age after that. Plenty of people just like Carol live with it for years before anyone puts a name to it. Doctors also use a staging system to describe how far the disease has progressed. A surgeon named René Fontaine developed it back in the 1950s, and it's still referenced today in clinics everywhere. Stage 1 is often silent, no symptoms at all, found only by testing. Stage 2 is Carol's pattern, that walk then rest claudication. Stage 3 and 4 involve pain even at rest and eventually skin breakdown. Doctors sometimes call that advanced state critical limb ischemia, and it's treated as a true emergency, not something to manage at home. Those later stages need urgent medical attention rather than a home exercise program on your own. Knowing which stage you're in changes everything about the right next step. A patient at stage 2, like Carol, is often an excellent candidate for exactly the walking protocol I'm about to describe. A patient already at stage 3 or 4 needs a vascular specialist involved first, before any exercise program begins. Why does this matter beyond your legs? Because the arteries in your legs don't operate in isolation from the rest of your circulatory system. If plaque is narrowing arteries in your legs, that same plaque-building process is very likely happening in other arteries too. That includes the ones feeding your heart and your brain. Research consistently shows that people with peripheral artery disease carry a significantly higher risk of heart attack and stroke than people without it. That elevated risk holds true no matter how severe or how mild their leg symptoms happen to be. Your legs, in other words, may be the first place this shows up simply because they're the first place to complain. Your heart's arteries could be narrowing the exact same way, silently, without any warning sign yet at all. I've had more than one patient over the years who came in for exactly this leg pain. We worked them up properly and caught a significant coronary blockage in that same visit. It showed up well before it ever caused a symptom of its own. The leg pain wasn't a separate problem sitting next to the heart problem. It was the same disease process, just showing up somewhere easier to notice first. Let's talk about how you'd check for this yourself, because there are clear signs worth paying attention to. The clearest one is the pattern Carol described: pain, ache, or heavy cramping in a calf, thigh, or hip. It reliably starts after a consistent walking distance and reliably fades within a few minutes of rest. If that pattern repeats itself, walk after walk, it deserves your attention. There are physical signs too: cooler skin on one foot compared to the other, skin on the lower leg that looks pale, shiny, or slightly bluish, hair loss on the lower legs and feet that wasn't there before, toenails that have started growing more slowly or thickening in a way they never used to. You can even check your own pulse in 2 specific spots. One sits on the top of your foot, roughly in the groove between your big toe and second toe. The other sits just behind the bony bump on the inside of your ankle. Press gently with 2 fingers, not your thumb, and give it a moment to find. A weak pulse, or one you genuinely can't find in one foot compared to the other, is worth mentioning to your doctor directly. This isn't a diagnostic test on its own, and it takes a little practice to get comfortable finding either spot the first few tries. Plenty of healthy people simply have pulses that are harder to feel by hand, but it's one more data point worth bringing to your next appointment. One common mix-up is worth clearing up here too. Some people confuse this with ordinary varicose veins, or assume compression socks are the fix, the way they might be for swelling. Compression is generally a treatment for vein problems, where blood pools on its way back up toward the heart. Peripheral artery disease is the opposite problem: blood struggling to get down to the tissue in the first place. In more severe cases, compression can be the wrong move entirely, which is why getting the correct diagnosis first matters so much. The definitive test your doctor can run is called an Ankle-Brachial index. It compares the blood pressure at your ankle to the blood pressure in your arm, using a standard blood pressure cuff and a small handheld device. It's quick and painless, and it's the test that actually confirms this diagnosis rather than guesses at it. A healthy ratio generally falls between 1 and 1.4. Anything below 0.9 is considered diagnostic for peripheral artery disease. Below 0.5 typically signals a more severe, advanced case. If your number comes back low, your doctor will likely order a follow-up test called a duplex ultrasound. It uses sound waves to map exactly where along the artery the narrowing sits and roughly how severe it is. That image is what guides your next step. It might be exercise on its own, a medication, or in more advanced cases, a procedure to physically reopen the vessel. This condition is also widely underdiagnosed, and not entirely by accident. A meaningful share of people with narrowed leg arteries have no classic claudication pain at all. That's especially true if they simply don't walk far enough day to day to ever trigger it. Studies looking at this consistently suggest a majority of actual cases go unrecognized, sitting quietly underneath a diagnosis of ordinary aging. That's part of why several major medical groups now recommend proactive screening for people at high risk, even before any leg pain shows up on its own. If you're past 65, or you smoke, or you live with diabetes, an ankle-brachial index is worth asking about at your next physical. That holds true whether or not your legs have said a word to you yet. One more distinction worth making clearly. Some people assume aching legs after 60 are simply arthritis settling in. Arthritis pain tends to behave differently. It's usually centered in a joint rather than a muscle. It doesn't reliably vanish within minutes of sitting down. And it isn't nearly as tied to one specific, repeatable walking distance. If the pain in your leg follows that same reliable start-stop rhythm, tied to distance and relieved by rest, that pattern points toward the arteries, not the joints. There is a prescription medication approved specifically for this claudication pain too, called cilostazol. It genuinely helps some patients, but in head-to-head comparisons, structured exercise therapy performs as well as the medication and often better without any of the drug's side effects. Most vascular specialists now recommend trying the walking protocol first, medication second, precisely because of that research. Now about that exercise I mentioned, because this is the part that genuinely surprises most patients. For decades, the instinct made sense to everyone, myself included early in my career. Leg hurts when you walk, so you walk less and let it rest. It seemed like basic common sense at the time. Research on peripheral artery disease has consistently shown the opposite approach works better. Structured, supervised walking is now considered the gold standard first treatment. It's recommended ahead of many medications and even ahead of some surgical procedures for people whose main symptom is that specific walking pain. A landmark analysis published decades ago and repeatedly confirmed since found that supervised exercise programs increased pain-free walking distance by roughly 180% on average. Maximum walking distance improved by more than 100% in that same body of research. These aren't small, marginal numbers we're talking about. A separate major clinical trial published in the journal Circulation directly compared supervised exercise against angioplasty. Angioplasty is the procedure where doctors thread a small balloon into the narrowed artery to physically open it back up. At both 6 and 12 months, exercise produced walking improvements that matched or exceeded the surgical option. It did that at a fraction of the cost and with essentially none of the procedural risk. Here's the mechanism behind why this works. Walking through mild to moderate claudication pain repeatedly stimulates your body to build new small blood vessels around the narrowed section of artery. Doctors call this collateral circulation. Your body is quite literally constructing a natural detour around the blockage over time. That process doesn't happen if you stop the instant discomfort shows up. The mild oxygen debt in the muscle appears to be part of the actual signal that triggers this adaptation in the first place. Comfortable walking that never quite reaches that point doesn't reliably produce the same result. There's a second mechanism working alongside the first one too. Regular walking improves how efficiently your muscle cells extract and use whatever oxygen does arrive. Even without a single new blood vessel, muscle tissue that's been trained this way simply performs better on a limited blood supply than untrained tissue does. The artery may still be narrowed. The muscle downstream gets noticeably better at working with what it's given. So here's the actual protocol, the same structure used in the clinical research behind those numbers. Walk at a normal pace until you reach moderate claudication discomfort. Not severe pain, just a noticeable ache. Stop and rest until it resolves, typically a minute or two, then walk again. Repeat this cycle for a total of 30 to 45 minutes. Do this 3 to 5 times a week. Research protocols generally run 12 weeks before measuring meaningful improvement, though many patients notice a difference sooner than that. Consistency matters far more than intensity here, week after week. There's no need to push through severe pain, and there's no prize for suffering more than the protocol asks. The target is moderate discomfort, an ache you'd rate maybe a 5 or 6 out of 10, not the sharpest pain you can tolerate. Pushing well past that point doesn't speed up the results, it just makes the whole habit harder to keep up with. A few practical notes make this easier to stick with. Supportive, well-cushioned walking shoes matter more than people expect, since foot comfort affects how far you're willing to go. A short, easy warm-up before the harder walking helps too. And tracking your distance, even roughly, gives you visible evidence of progress over the weeks, which tends to keep people motivated when day-to-day changes feel small. A treadmill works just as well as walking outside, if that's more practical for your schedule or the weather where you live. Some clinics run formal supervised programs specifically for this, with a physical therapist monitoring you through the cycles. If one exists near you and your insurance covers it, that supervised structure tends to produce even better results than going it alone. Someone is there keeping you honest about reaching that real discomfort point instead of stopping early out of habit. If you don't have access to a formal program, an ordinary sidewalk, a local track, or a treadmill at home all work. What matters far more than the setting is the actual cycle itself. Walk to that real discomfort, rest until it passes, and walk again for the full 30 to 45 minutes, several days a week. One important note before you start anything like this on your own: if you're already diagnosed with peripheral artery disease, talk to your own doctor before beginning a structured walking program. The same goes if you simply suspect you might have it, based on everything I've just described. They'll want to confirm the diagnosis first and rule out a few specific situations where this particular approach isn't appropriate yet. Specifically, pain that occurs even while you're resting is a signal to get evaluated promptly. So is any open sore or wound on your foot that isn't healing. Don't start an exercise program on your own with either of those present. Those particular signs can indicate a more advanced stage of the disease, one that needs a doctor's direct involvement first. For most people with the classic walk-then-rest pattern, a doctor will very likely send you toward exactly the kind of structured walking I just described. Sometimes that happens through a formal supervised program at a clinic. Sometimes it's simply a prescribed habit you build on your own, with checkups along the way. Now let's look at what causes this narrowing in the first place, because prevention matters just as much as treatment does. Smoking is by a wide margin the single strongest modifiable risk factor for peripheral artery disease. Research shows smokers face several times the risk compared to people who've never smoked. That risk drops in a measurable, meaningful way within just a few years of quitting for good. Diabetes roughly doubles the risk on its own. It also tends to make the disease progress faster once it's already present, and it complicates things further downstream. High blood sugar over years damages small nerves in the feet too, which means some people with diabetes lose sensation right alongside their circulation. That combination is exactly why a small cut or blister can turn serious before anyone notices it happening. High blood pressure and high cholesterol both contribute steadily over time, the same way they damage arteries everywhere else in your body. Age itself is a factor too, with risk climbing noticeably after 60. None of these factors work in isolation from each other. Someone managing several of them at once faces meaningfully higher risk than any single factor alone would ever suggest on its own. There's also a piece of this that has nothing to do with anything on your chart. Sitting for long stretches, day after day, without much walking at all, appears to be its own quiet contributor. Muscles that rarely demand blood flow don't get the regular signal to keep those smaller supporting vessels open and healthy. Some people go from physically active jobs into a much more sedentary retirement, the way Carol did. That's part of why symptoms sometimes emerge in exactly that window, right after decades of daily walking suddenly stop. Let's bring this together into something practical you can put to use this week. First, pay attention to the pattern. Does leg pain show up reliably after a consistent walking distance and fade within minutes of rest? That specific rhythm is the detail worth mentioning to your doctor by name at your next visit. Second, check your foot pulses and look at your skin, your hair growth, and your nails on both legs. Note anything that looks or feels different between the two sides. Third, if the pattern fits, ask your doctor specifically about an ankle-brachial index test by that exact name. It's quick, it's painless, and it gives a clear answer instead of a guess about what's going on underneath. Fourth, if you're cleared to start, Walk on purpose, into the mild discomfort, then rest, then walk again. 30 to 45 minutes, 3 to 5 days a week. Give it real weeks, not just a few days, before judging whether it's actually working for you. Fifth, if you smoke, this is one more serious reason to make quitting the priority. It's the single biggest lever you actually control in this entire picture. Carol, by the way, stuck with her walking program for a little over 3 months. The first few weeks were genuinely frustrating for her, stopping every block or two, watching the clock more than the scenery. By week 8, she was making it to the corner store and back before she even noticed the ache starting. She can now make it to her mailbox and well past it without stopping once. She still jokes about her old lady legs, but these days it's clearly a joke, not a quiet worry sitting underneath it. Think about her pain the way you'd think about a warning light on a dashboard. It was never just an inconvenience to work around. It was information. Ignoring it wouldn't have made the underlying problem disappear. It would only have meant driving in silence while that problem kept building underneath. I think about Carol every time a patient waves off leg pain as nothing serious. The instinct to protect a hurting body part by resting it is deeply built into us. Overriding it takes deliberate, conscious effort, even once you know better intellectually. That's why I wanted to walk you through the reasoning today, not just hand you an instruction. Understanding why the walking works seems to be what gets people to stick with something that feels wrong for the first few weeks. If walking has quietly gotten harder for you, or for someone you love, that's worth a real conversation with a doctor. It deserves more than just a slower pace and a shrug. It's such a small thing to bring up at an appointment. One sentence, really. My legs ache after about 2 blocks, and it goes away when I sit down. That single observation, said out loud to the right person, is sometimes all it takes to catch something years before it becomes a much bigger problem. Tell me in the comments if this pattern sounds familiar, either for yourself or for a parent you've noticed slowing down lately. Tell me honestly how far you can walk before it starts, if you know the answer offhand. I read every single comment, and it genuinely shapes what I cover next. Maybe this changed how you'll think about your next walk. Maybe it convinced you to check your own pulse tonight. Either way, send it along to someone who genuinely needs to see it. A pattern like Carol's is far easier to catch early when someone nearby is paying close attention too. Go ahead and hit subscribe and flip notifications on because the next one matters. I'm finally covering something I've promised more than once now, a medication a huge number of you take daily for cholesterol. I'll cover the nutrient it may be quietly draining from your muscles the whole time you've been taking it without knowing. Walk on purpose, rest on purpose, then walk again. Don't just sit down at the first sign of discomfort and quietly call it caution. I'm Dr. Walter Hale, and sometimes the most protective thing you can do for your own body is keep moving through it.